Hi, you guys. Welcome to Ask the Egg Whisperer. I'm so excited to be here to ask your questions. If you guys have a question, feel free to go to asktheeggwhisperer.com and I just answer them as they come in on this show. I'll be having more and more doctors join me because it's super fun to talk to doctors all over the world to see what their perspective is about the questions that you guys send in. So I love doing that. I love hearing from you guys, and thank you for sparkling. I know that sounds cheesy, but if you guys know me in my heart, I'm one of the most incredibly positive people in the whole world, and I always have hope. And what hope means for me and my patients is to have only pragmatic, I didn't flip you off there, see, pragmatic and positive expectations. So that's what hope means to me. So right now we're all going through a really tough time, and when people come up to you and they say, "How are you doing?" the easiest thing to say is, "Oh my God, I'm barely hanging on." And that honestly is how a lot of us feel, and sometimes even me, but I have to turn that around and I say to people, I'm feeling really strong and resilient today. And I just to remind myself that over and over and over again, and then suddenly it starts feeling that way, that you're feeling strong and resilient. Because going through what we're going through right now in the world and being a fertility patient, and you put it all together, you're at high risk for things like depression, anxiety, and PTSD. So your mental health is super important to me. So thank you guys for being here. And I'm going to jump right into the questions right now. So the first question is from Brittany. Brittany, thank you for asking this question. I think it's a really important one. And she says, "Hi, Dr. Aimee. I'm so incredibly grateful for your show and positivity. It's truly keeping me afloat right now on this journey. I am a 33-year-old woman. My husband's the same age. Trying for about 2 years. Ideally, I want multiple children. I had a case of PID. My IUD got infected when I was 20. The only diagnosis they have for me, I've been to 2 different clinics, is unexplained infertility. They say my tubes might be scarred from PID, but the saline histogram showed no abnormalities and perfect openings. Maybe endometriosis runs in my family. Maybe it's PCOS, no definites on anything. So we've just started our first IUI with Femera, so I'm trying to stay positive. Her question is this: how many rounds should I do before moving on to IVF? And what can you suggest or recommend for my situation? I'm supplementing and exercising, walking with light weights, doing yoga, and trying to remain light and positive. Please help. Thank you so much for all you do." Okay, Brittany, thank you for all this background, because while you've been given this unexplained sort of diagnosis, it feels like there likely is an explanation. Whenever I have a young patient like you, and it sounds like everything else around you is great, no fibroids, no polyps, good sperm, the tubes, in my mind, are blocked until proven otherwise. So you had something called a saline histogram, but it may not be as good of a test as something like a hysterosalpingogram or a laparoscopy. So in my gut, I worry that if you had an infection from an IUD, you could also get an infection from an IUI, which stands for intrauterine insemination, for those of you guys who don't know. So what I'm thinking for you is consider doing a more better test. I know that wasn't good grammar, but you know what I mean. Consider doing another test to look at your fallopian tubes. However, my concern there would also be risk of infection. So I would say, because of the infection that you had from the IUD, it's possible that the fallopian tubes might be blocked, and IVF is the way to go to build your family. So I wouldn't necessarily spend too much time doing fertility pill IUI cycles given your history. Think about endometriosis for sure. Think about PCOS and measure all your hormones and see what needs to be balanced. But in your case, if you have symptoms of endometriosis and we're worried about tubal blockage, maybe the safest test to do is a laparoscopy procedure. But if you are a patient of mine, I would be talking about embryo creation. And the reason is, you guys all know my Egg Whisperer golden rule. One of them, there's many, but one of them is, if you're 32 years old and you want more than 2 kids and you don't have one already, consider fertility preservation, securing your options for the future. And in a case like yours, when you're already partnered and it's taken you 2 years so far to have baby number 1, we talk about making embryos for your future, and the way you do that is through IVF. So thank you, Brittany, for your question. And remember, take CoQ10. You guys know I always say that. And I should also say, if you're considering IVF and want to learn more about it, you can join my Egg Whisperer School, and I have an IVF class coming up. I do one every 2 weeks or so. So do join my class, and then you'll learn more about my tips and tricks, so to speak, as to what I want patients to know before their IVF cycle to give them the best chance of pregnancy. So this is a great question. This is from Janie, and Janie is asking, what are your thoughts on HGH wash? Could you use HGH subcutaneous instead? Have you seen benefits with it? I will be going for my 4th transfer soon and thinking of asking for it. So Janie, that's a great question. When I think of preparing for a transfer, I always ask, have I done preconception labs, for example, to make sure the thyroid's normal? Is my patient in the best shape of her life? Is the uterine cavity gorgeous? Are there any polyps or scar tissue or anything that can block the way of an embryo from implanting? Have I done implantation testing? Have I done, for example, the ERA test and the receptiva test? Should I start thinking outside of the box and think about things that we look at if someone has recurrent implantation issues? For example, would you benefit from doing a thrombophilia testing or autoimmune testing? You see what I mean? There's so many things to think about before you even start thinking about HCG wash, and I'll tell you just a little bit more. And at the end of the day, if you're having recurrent implantation issues, you have to say it's either the embryo or the uterus. It's either the seed or the soil. And so we got to look at both things. So remember the embryo diamonds, the 8 things you need to know about your embryos. If you guys don't know what I'm talking about, go back to one of my previous shows and I talk about all the things you should know about your embryos. But a few of them are, what's the implantation rate based on the embryo quality? And are they genetically normal or not? So let's say you've done all of this stuff that I'm talking about. You've done it all and you still haven't had an implantation yet. Then I would say maybe think about some advanced immune genetic testing like HLA-KR testing. This is controversial, I know, but it's something that I offer my patients, and there are other doctors out there that do this. Doesn't mean everybody needs to do it, but we as human beings like answers. And so this is something to consider doing with your doctor if they agree. But HCG wash was a fad. It was a fad, and then it went away, and then it's coming back again, and it's probably going to go away. And in the studies that I participated in, this was maybe like 10 years ago, believe it or not. I know, hard to believe that I was practicing medicine 10 years ago when I have a face that looks like I'm only 70. But basically what I'm trying to say is I have not seen an improvement in implantation rates with HCG wash in my practice. But if your doctor feels like that's something that they want to try for you, maybe consider it. But I would say consider doing all the things that I already mentioned first before you add that in. So this next question is from Cristina, and Cristina is 26 years old. She was diagnosed with ovarian cancer in July of 2020. This was after she had surgery to remove the mass from her left ovary. The mass was the size of a basketball, and she lost her left ovary and left tube. This is what she says: I still have my right for now, as I'm still navigating the cancer diagnosis. Where should I start with trying to save my fertility if I can? What questions should I be asking my doctors? Thank you, Cristina, for this question. So this is what I would do if this were me. Number 1, genetic testing. Consider doing carrier screening for the universal, the list of recessive genes that we look at, but also look at the high-risk cancer genes. There are about 80 or so out there that we know of, and talk to your doctor if they haven't done this testing already, because this could certainly help help you create a roadmap for yourself as far as when to consider maybe removing that other ovary, depending on what your cancer diagnosis is from the ovary that they removed. For example, if you had a high-risk gene like a breast cancer gene, you might want to consider, for example, removing your ovary when you're done having kids by the time you're, let's say, 40 years old. But certainly talk to your doctor first. This show is not in place of any expert guidance from your own personal physician. I'm just kind of talking about things that I would think about for my patients in a similar situation as you, but I certainly don't know everything about your story. The other thing that I would consider doing is talk to your doctor about a referral to a fertility center who feels really comfortable freezing your eggs, right? So get an AMH level done, anti-Mullerian hormone. This hormone is a blood test that tells you basically what your reserves are, how many eggs they could possibly get, and then talk to them about what are your risks going through an egg retrieval at your age with your diagnosis being exposed to hormones. So you feel really safe going through the process with your doctor. And then talk to your doctor about the 3 questions that I always ask my patients. What do you want? What is it going to get? What is it going to take to get what you want? And are you willing to do it? So what do you want? So at 26 years old, it sounds like you really want to have a family, and that's awesome. But then let's dive deep a little bit more and say, how many kids do you want? So if it's like, I always dreamed of having 3 or 4 kids, you want to make sure that you've had enough eggs frozen for yourself so that you can do embryo creation in the future at a time where you might not have as many options, and now you've given yourself all these options. So many people regret not having this talk, right? Not going through the 3 questions, because they feel like if someone had done that for them, then maybe they would have done more, frozen more when they still had eggs. For example, I think I can reliably say that 100% of my patients over the age of 40 wish they had frozen eggs from when they were 26. I do think so, because rather than going through cycle after cycle after cycle after cycle when you're over 40, rather than having, let's say, just a set of eggs from 26, you can imagine that that would have been a lot more efficient. But technology wasn't the way it was back then as it is now. It's way better now, but I digress. So my point is this, Cristina, freeze your eggs. If you're partnered and you think you might want to have kids in the next, several years, consider freezing embryos. You can also consider doing half and half with donor sperm. If you want to be a solo mama by choice, so many things for you to consider doing. So many awesome options for yourself. Okay, so this next question is from Michelle. So Michelle is saying, I started my fertility journey in January as natural monitoring. I have a family history of decreased ovarian reserve. I'm taking supplements for decreased ovarian reserve since July. My sister got pregnant with an FSH of 19 on her own at 35, which is my age and also my current FSH this month. My doctor will not do IVF with me because my AMH is 0.14, my FSH is 19, and stated that they will do natural monitoring with Ovidril injections if the follicle is at least 23 millimeters or more. So Michelle is asking, what advice do you have for me? I feel so lost at this point. Any at-home remedies I can be doing? Any suggestions as to should I get a second opinion? So Michelle, you're a 35-year-old woman. You're healthy and young as far as I'm concerned. I would make sure you've done all the proper genetic tests that your doctor recommends. For example, looking at Fragile X, looking at for example, a chromosome analysis. You can check your Fragile X by getting just a carrier screen. I imagine that this could be genetic or autoimmune, or maybe a combination of the two, given that your sister sounds like had a similar thing. But your sister's your sister's story tells us not to lose hope and to keep having hope, which again is to have only pragmatic expectations and practical and positive expectations. And it sounds like you still have a lot of hope in your heart, because if you didn't, you wouldn't be here asking this question of me. And I would say find a doctor that believes in your fertility. At 35 years old, you have the eggs of a 35-year-old. You might not have several eggs, but it sounds like you probably have 1 or 2 with an AMH of 0.14. I would start CoQ10 if you aren't already. Consider seeing an acupuncturist, get in the best shape of your life, doing strength training, following a plant-based diet. I have lots of YouTube videos all about lifestyle and mental health and things that you can learn about how to get yourself in the best shape possible, both mentally and physically, before you go through an IVF cycle. And also join my Egg Whisperer School and sign up for my next IVF class. But if you are a patient of mine, I would absolutely give you a chance at doing IVF. And there are other doctors just like me, not only all over the country, but also all over the world. So find one of us and ask for a procedure or a process of IVF called mini IVF. Some people call it mild IVF, some people call it soft IVF, but that's kind of what I would consider if you were a patient of mine. Also, don't forget about the tubes, don't forget about the uterus, and don't forget about the sperm. So look at all aspects of your fertility and go through the 5 things that I talk about when I talk about the Tushy method. For those of you guys who don't know what the Tushy method is, just go to tushymethod.com and you'll see exactly what I'm talking about. So thanks for that question, Michelle. Okay, so here's a question from P. P is asking me, when is it typical to stop progesterone after a frozen embryo transfer? I'm 11 weeks, 4 days, and per my doctor, I took my last dose of 0.25 milliliters of progesterone and oil today. Some of my friends stopped much earlier. How do you know that the placenta is adequately taking over progesterone production? Does stopping it too late inhibit the body from naturally producing progesterone as it gets used to the artificial supplementation? Okay, P, here's the deal. The placenta takes over between 7 and 9 weeks of pregnancy. So even going past 9 weeks, Probably not necessary. In this country, we tend to go to at least 10 weeks. I go to 10 weeks, but I know patients are so nervous about stopping cold turkey at 10 weeks. So I talk to my patients and I see how they feel. And some patients I stop at 10 weeks, especially if they're feeling super nauseous and having lots of symptoms of pregnancy. In other patients, I'll start to taper at 11 weeks, maybe go every other day, and then every 2 days, and then every 3 days until maybe they stop at 12. Some patients just feel more comfortable stopping at even 14 weeks. But the placenta is making it. So by supplementing, you're not tricking your body into doing anything that it wasn't already doing on its own. You're just adding a little bit more. And my philosophy is that there's no such thing as too much progesterone unless your doctor thinks it's too much. Meaning, progesterone can sometimes make you feel a little dizzy. It can exacerbate your symptoms of nausea. It can decrease your mood and make you feel kind of lousy. So any opportunity I have to decrease the dose and stop it completely, I will take it. And for most patients, it's at 10 weeks of pregnancy. And so I don't want you to worry one bit about what your doctor has done for you, because I certainly do that for my patients too. Okay, guys, thank you for your questions that have been messaged. I'm going to do this again tomorrow. But right now, I'm going to scroll through and see if you guys have any live chatted questions. And if you don't, I will see you again tomorrow. So let's go here and see. So this is a great question from Joyce. Dr. Aimee, before the frozen embryo transfer, how much water would you suggest drinking? How long in advance? Many thanks. Okay, guys, so when it comes to water, let's ask, why do we need to drink water? So the uterus can be like a lawn chair. The bladder sits right here. As it fills, it straightens out the uterus and flattens out that lawn chair so that when I come in with the catheter, I'm going straight into the uterus. If you could imagine, the catheter is like this. It doesn't have that much of a bend to allow me to get around or get through that bend. So that's the reasoning behind having a full bladder. I recommend 2 8-ounce glasses of water starting about 2 hours before the transfer. And I tell people, look, I have all the patients in the world. It's a lie, actually. I have like 0 patients. But I have all the patients to make sure that my patients have the very best chance at pregnancy success with their embryo transfer. So I tell patients, if you're not full enough, no big deal. I'm just going to hang out and wait until your bladder fills up. If your bladder's too full, my trick is to sing row, row, row your boat, because that seems to be the right amount of time you need to empty your bladder just enough so it's perfect. So those are my little bladder tricks. 2 8-ounce glasses starting 2 hours before, and then just don't worry. And use your voice. If you feel like you're going to pee on somebody, don't pee on me. But if you feel like you're going to pee on someone during the transfer, use your voice. Just say, can I just use the restroom for 5 seconds? And then go sing row, row, row your boat. If you feel like people are struggling while they're trying to look at your uterus, you can say, you know, guys, I don't feel comfortable starting my transfer right now until you guys can see a lot better. So I'd like to wait until my bladder is fuller. And the reason why I say this is because I've had patients come to me and they share these stories of they couldn't see my bladder and they went with it anyways. And then you feel like this tremendous loss because you're like, if it were me, I'd be like, stop, wait for my bladder to fill. You know what I mean? So I tell my patients when I'm doing procedures on them that there are 2 words to use, slow or stop. I said, it's as easy as that. If I'm doing something and you want me to slow down or you want me to stop, just say the word stop. Because I feel like as women, we're always like, oh, I'm so sorry. Oh, I'm so sorry. And we're worried that we're going to offend somebody. But this is really deeply personal stuff. It means so much to us. It means so much to me to just get it right as much as I can the first time. Because I know when I'm dealing with human biology, it's just not possible. But I certainly try to aim for perfection. Get it? AIM. And my name is Aimee. I don't think that was an accident. Okay, let's see here. This is a question about HGH priming. What is the dosage you use for your patients? So for those of you who don't know, I actually have HGH here in my drawer. And no, I do not use it myself. Although I know I look like I'm 25 when I'm really 75. So I lied. I don't have a vial here. Oh, I do. So here's what HGH looks like. I have my patients use the generic name Omnitrope, and it just is a powder. And you turn the dry into wet, and you just draw up 25 or 0.25 mLs every 3 to 4 days. So I just tell patients the schedule's like Tuesday, Friday. It's not time sensitive, morning or night. If you forget it, no big deal. Just do it the next day. Okay? So that's how I do it with my patients. Great question. This is a question from My Happy Place. Love your profile name. I'm 33 years old. I had 3 fertilized eggs that have been sent for genetic testing. I'm waiting for the results. Should I do another round of IVF? Let me look into my crystal ball. I have no idea, but that's a great question. Remember my 3 questions, right? What do I want? What is it going to take to get there? Am I willing to do it? So if you have 3 embryos that are going to genetic testing, you want to ask your doctor, the embryo diamonds, remember the 8 things you should know about your embryos. What day were they frozen? What's the implantation rate? Which one's abnormal, normal, or mosaic? I need to see the official reports. Will they help me reach my goals and dreams? And let's talk about sex. I'm just kidding. That's not the S. The S is, what was the sperm on the day of the egg retrieval? That's really important to know. So I know that wasn't your question. Your question was, should I do another cycle? But that's the information that I need in order to answer your question. I want to make sure you guys know what questions to ask. And I get this question a lot. Like, this is what's going on with me. Like, what questions should I ask? And unless you know what questions to ask, how are you going to know what you should know, right? So now that you know what you should know, you're going to be more in the know. And then you're going to be like, I'm in the know. So if, let's say, you have 3 embryos and 2 are amazing and you really want 2 kids and you're 33, I would say, ask your doctor, what are the chances if in a year and a half I need to do IVF again, if my second embryo did an implant, would I be able to get another embryo? Ask that question. And if the answer is, I think it's better to do another cycle now, then do it now. And don't wait 2 years. But at your young age, the likelihood of still being able to get another normal, even in a year and a half from now, is going to be pretty good. Okay. Just going through to see if you guys, oh, that's so cute. Someone asked, are you an actual angel? That's very funny. I am not. My sister would say I'm the devil. Okay. Here we have someone saying that she's 4 days post 5-day transfer, transferred 2 embryos, negative pregnancy test today. Should I still be hopeful? And the answer is yes. I've seen positive pregnancy tests on urine tests even at 7 days post-transfer, at 6 days post-transfer, even on 8 days post-transfer. So there's still a chance that this cycle could work or this transfer could work. And I know it is so hard to get through that 2-week wait is what people call it, but just hang in there. And that's one of the most annoying things anyone could tell me is hang in there. But just know that each experience you have, even if it doesn't work, is going to inform you as far as what you should be considering next. So I really hope and pray that your 2 embryos implanted and you're going to have good news for us very soon. So someone is asking, they're curious about the frozen embryo transfer timeline after an egg retrieval. Just had an egg retrieval on Tuesday, started progesterone and Lupron next week. Let's see. Just had a retrieval on Tuesday, started progesterone and Lupron. I don't know about next week, but as far as egg retrieval, I think I know what you're saying. You did an egg retrieval and you just started the other day your progesterone. So let me just kind of break things down. When it comes to IVF, you have options. You can do an egg retrieval and transfer an embryo fresh, meaning just pop it in 3-5 days later. The other option is you can freeze your embryos and transfer in the future. There's no such thing as freezer burn. And 2 weeks after the egg retrieval marks your ovulation day is when your period starts. After your period starts, we like to mimic ovulation with drugs like estrogen and progesterone. Typically it's 3 weeks, 2 weeks of estrogen, and then the 3rd week is estrogen and progesterone leading up to the transfer. Then you continue your medications until 10 weeks of pregnancy. On your transfer day, you're about 2 weeks, 5 days pregnant. So you continue the medications for almost 8 weeks. Got it? Okay, I'm almost done. Lupron, we use Lupron. Think of it as suspenders when you're already wearing a belt. So the high dose estrogen prevents your pants from falling off, which is ovulation. And if you have suspenders on, your pants will probably not ever fall off, but sometimes it still happens. The reason is that we do not want patients to ovulate when they're in their frozen embryo transfer cycle if we're using a medicated protocol, because ovulation means progesterone is going up before we're ready to put an embryo in. So that's why we try and sync all this stuff up. We have all these fancy recipes to make our momlets in the IVF kitchens, and so we don't want the ovaries to have a different plan in mind because that can get in our way of a healthy implantation. So I hope that helps. Okay, so this is a question. What's your recommendation for synchronization issue? Besides priming with estrase, I'm still having a lead follicle issue. What's your recommendation treatment protocol to avoid post-mature eggs? Okay, Ladybugs SF, here are some more creative things that you can do. Number 1, a luteal phase stimulation. So see your doctor a week after ovulation and see if they feel comfortable doing that. I used to be like, oh my God, this is so crazy. I can't imagine doing it. And now I'm like, oh my God, it's actually quite amazing, especially in cases like yours. Thing two, consider estrase priming, which I think you already said. Look at how you're doing it, how much you're doing of it. And then when you're starting your hormones, like, are you waiting for a period? Because some people recruit an egg to ovulate even like a day or two before their period starts. So you might need to actually start stimulation before your period starts. Thing three, option three, I know these aren't things. Option three is to consider being seen earlier in your cycle so that you can add the antagonist sooner. So maybe like start stim for 2 days or the third day and go in on treatment day 4 or on cycle day number 5 and see if adding the antagonist early would be helpful. Other possibilities would be kind of crazy here. You're making me think of all these things, and I appreciate you asking me these questions so I can bring these up so you guys can take them to your doctor too to see if they've considered these things as well. Other option, consider a long Lupron protocol, maybe just up until a few days after you start stim, stop it, and then go to an antagonist protocol, bringing in the ganirelix. And you can do that with even a microdose flare. So I'm getting kind of fancy here, but these are the options that you can consider for yourself. Okay, dear Dr. Aimee, this is from Joyce Moon 66. How would you instruct your patients to use Crinone? Not rectally, swear to God. I've had people say, and I actually Googled it and read it online. They're like, I get that buildup in my vagina. Is it okay if I can put it in my rectum? And I'm like, whoever told you that, like, hates you so much right now, like so much that person should never be your friend. Like, unfriend them, defriend them, block them, whatever you can do, never your friend. For those of you who don't know what Crinone is, it's basically a tube and it has a gel inside, and the gel is basically progesterone, and you put it in your vagina. So Crinone is great. It's just super expensive. It's like crazy expensive. I think one Crinone applicator is like $15. And the dosing is 2 times a day. And sometimes I even have my patients do 3 times a day. So as far as Crinone, I mean, I think it's a great medication. It's just so expensive that it's not something that I recommend. I prefer either doing progesterone in oil and or the endometrium inserts. They're both kind of icky, and you get that vaginal slime that I described to people. But the Crinone's a little cruddier, and the endometrium is a little creamier. Am I losing you guys? I know that's totally disgusting, but in my world, that's just called life. So this is a great question from Ashley. What's the best age to freeze your eggs? And so egg freezing is for anyone in their 20s, 30s, 40s, and who knows, maybe one day I'll be saying 50s and 60s. I do predict that will happen at some point in the future when we figured out a way to unlock ovarian aging and the key to that and how to reverse it. But for now, what I tell people is you can't put Botox in your ovaries and you don't age backwards. Until then, freeze your eggs. Consider freezing your eggs at a young age. A lot of times people just wait until sometimes it's too late to freeze enough viable eggs to help themselves in the future. But you don't really know until you see a fertility doctor. Get your AMH, FSH, estradiol checked. Do genetic testing too before you freeze your eggs. That's what I recommend to my patients. So that's a little tip for you to think about. And see a fertility doctor that believes in you. I've frozen an egg from somebody, 1 egg, for it to turn into a healthy pregnancy. I don't have that many stories of that, but a lot of times people share with me stories that they went to their fertility doctor and the doctor refused to freeze eggs for them because they said it wasn't worth it and there weren't enough eggs to freeze. So my thing is that sometimes just going through the process makes you feel better about your future, and I think just doing it for that reason is okay with me, as long as you have the pragmatic and practical expectations of what the treatment will do for you. So if, let's say, you're 42 or 43 and you have maybe 3 eggs to freeze and you don't feel comfortable making embryos, I think that's okay. If you're 37 years old and you might have 5 eggs to freeze, as long as you know what the potential rate of normalcy would be for each egg if it turns into an embryo and that's worth it for you, go for it. But also think about other options for creative family building, especially if you're over the age of 38, if your frozen eggs don't work. And I always encourage my patients and anyone who wants to get my advice is to consider using your eggs at a time when you still might have eggs left. And the reason is you don't ever know, never ever know what an egg's gonna become until you turn it into an embryo. And it's super annoying to turn your eggs into an embryo and find out that there were no embryos when you're like 46 years old and you don't have any viable eggs left. So I hope those tips helped you. And remember, take CoQ10. Okay. So someone is saying, I left an Omnitrope vial out of the fridge for approximately 24 hours. Do you think it's okay? So if you call the pharmacy and ask them, they would say, it is not okay. If you called me, I would say, it's probably okay. Trying to get pregnant naturally. I'm 38, just had my uterus checked on cycle day 3 and found plenty of eggs in my ovaries. All hormone testing is all normal. And I can't see what the question is, but that's okay. Maybe I'll get to it. How long does a mixed omnitrope lay good for? I use it for a previous cycle and be using it for my next cycle. So if you read the bottle, it says if opened within 30, if mixed and not used within 30 days, discard. My thing is, probably still okay to use. This patient is saying, or sorry, not patient, that's how I think. Someone is saying, I have 2 embryos frozen. Is it possible to do genetic testing still and refreeze again? And the answer is yes, but talk to your doctor. So you want to know what day were your embryos frozen, how good quality are they? If they're low quality, day 6, already hatched out, for example, you don't want to thaw, biopsy, and refreeze. If they're, let's say, 4 BBs on day 5 and thawing them, biopsying, refreezing would be perfectly safe and your doctor agrees, then do it. But not all centers feel comfortable with that. It's not as easy to biopsy and refreeze an embryo than to biopsy and freeze it when it was fresh. So talk to your doctor directly about that. Okay. So this question is, any success stories dealing with Y chromosome deficiency? Had 2 failed cycles, no eggs to freeze on the first cycle, 1 frozen egg on the second cycle, did PGT and turned out abnormal. So I think what you're saying is that you probably have some issues with severe male factor. And so I would say, look at my balls method, look at all those things in balls, look at background genetics. You already looked at the Y microsome. Oh my goodness gracious. Today I told someone I was going to tweak their cycle, and you know what I said? I'm going to twerk your cycle. And then I told someone else I was going to start their meds, and I actually said I'm going to shart your meds. Thank God for the mask, because I feel like people actually aren't hearing the word mumbo jumbo that sometimes I say out loud. So the Y chromosome microdeletion you've already done, but look at sperm DNA fragmentation, look at the overall quality, and ask the doctor if it makes sense to consider doing chromosome analysis on both of you, and if it makes sense to get the sperm a different way, like a testicular extraction, like I talked with Dr. Evans about earlier. So this is a question from Aimee. I'm 28 with PCOS and do not ovulate on my own. I've tried 2 cycles with letrozole and Ovidrel with timed intercourse. Recently I had an IUI with the same drugs. Should I move on to IVF or continue IUI? Okay, so I think it really depends on what your goals are, how many kids you want, and what the sperm quality looks like. Have you ruled out have you done the Tushy method? Are the tubes open? Is the uterus great? No polyps? Is the sperm amazing? Does the sperm sparkle? I do imagine sperm sparkling. I do. When your doctor is putting it in, like, do you feel really good about the timing of everything? And I know you've already done 1 IUI, but I would say make sure you've healed your PCOS, that the hormones of PCOS are balanced. Dive deep there and make sure that that's done, because even if you did IVF, if you didn't take care of your PCOS, you're going to have a lower chance of pregnancy with IVF. So if you were my patient, I would say, let's try a couple more cycles. Let's make sure your PCOS is optimized and very well managed, that your BMI is healthy, that you're on all proper supplements, your testosterone is normal, your vitamin D is normal, your prolactin is normal. See the list I'm giving you right there? So I would go into your doctor and say, what have you done to make sure my PCOS is well managed? Easy. You don't have to go in with that list, and then they'll go through what they've done, and then that might make them say, oh, you know what? I actually haven't checked your testosterone recently, and maybe that's important for us to do. So that's kind of how you can help things along as a patient. This question is from Maria. Question, I'm 37. My antral follicle count is 16. My AMH is 4. I have a normal hormone profile. I have male factor infertility, no past IVF. Antagonist protocol is what they're planning. What's the highest amount of FSH you'd consider starting with? Would you do recombinant or pure? So in a case like yours with an AMH of 4 and an AFC of 16, I would repeat the AMH. An AFC of 16 is probably consistent more with an AMH of around 2 or so. So I'd be curious about what's going on there, because if your AFC is 17 and your AMH of 4, there's something that's just not matching up. And it's not unusual. About 1 in 5 patients will have an AMH that doesn't quite match up with their follicle count. So the other thing is look at your day 3 FSH and estradiol. If there's any hint that you might have an egg quality issue aside from just being 37, which to me, you're a young, healthy woman. And it sounds like you know your diagnosis, which is male factor. And I always think about diagnosis before treatment. So now design your IVF cycle to address the diagnosis. So make sure you're doing ICSI, do a DNA fragmentation test if not done already. Ask your doctor if they have other options for you to optimize the sperm quality on the day of the egg retrieval. So what I'm talking about is something called PIXI or Zymote, ZYMOT. So go to zymotefertility.com Or look at Pixie on YouTube. You'll see some cool videos if you put Pixie, and then the name of the company that makes the plate is Origio, Origio, for those of you guys who are going to geek out and do stuff like that, because it's super fun to actually watch sperm on slides. That's kind of what I enjoy doing. I was kind of daydreaming the other day. I wasn't daydreaming. I was actually thinking of baby making. And my husband says to me, he's like, how's the baby making going? I'm like, how do you know that's what I'm thinking about? And he's like, that's all you think about. I'm like, I know. That's exactly what I was thinking about right now. Okay, so sorry, Maria. The answer to your question as far as how much would I start with, I would say depending on your BMI, I would rather start with a healthier dose and go down earlier. But I would say, usually around 450 for someone who has about 16 follicles, and then bring you in after maybe 4 days and then see what your estrogen level is and then go from there. But I use a combination of estrogen and, FSH and Menopur. This question is from Pre. Hi, doctor. A couple weeks ago, I asked a question about my AMH being 0.09 and FSH 15. I'm getting retested tomorrow. With a number like mine, would IVF be successful, or would be looking at an egg donor be better? Okay, so it really just depends on your age and how you're going to feel after you get pregnant with an egg donor pregnancy. This is what I tell my patients. Fast forward, you have that gorgeous baby in your arms. Would you ever look back and say, I wonder what would have happened if I had tried with my own eggs? If the answer is yes, and financially it's doable for you, go through the motions, see what happens. If it looks like you're going to have at least one egg to retrieve, and that's really important for you to have that experience, to feel like you tried, and to have what I call IVF closure before you go to donor egg, go do it. But if you're going to look at that baby and say, I wish I had done this sooner, forget about it. Move on, have your family. I want you to be a parent more than I want you to continue to be a patient, and just focus on doing what will get you what you want. And it sounds like it's a baby. It sounds like you're open to creative family building options. So go do it, and be sure to see a therapist ahead of time. That's what I recommend to all my patients, not because my patients need someone to tell me that they'll be good parents. No, all my patients are going to be good parents. What I want the therapist to do is kind of talk through these scenarios and make sure you feel really good about this option and are truly ready and don't have any second doubts. Okay, this is a question from Liz. How soon after laparoscopy for endometriosis can you do a frozen embryo transfer? So Liz, it really depends on how you feel after the laparoscopy. If you were my patient, this is what I would do. I would say, as soon as your laparoscopy is done, call me. Actually, not quite. I say, in the next week, and we actually schedule it, we do something called a post-surgery consult. I review all the images with you. I review how you feel after the surgery. And then I say, how would you feel if we started FET meds, which is frozen embryo transfer medications, to get ready for a transfer in 3 weeks? So I have some patients that are like, I'm so ready, like I'm going to stop the birth control pill, because most patients are on the birth control pill leading up to the surgery. They say, I'm going to stop the birth control pill today, and we're going to transfer in about 3.5 weeks. I have other patients that are like, oh wow, yeah, that didn't feel so good. I'm feeling a little bit distended, and I need a little bit of time to myself. So give me a couple of weeks and we'll regroup in a couple of weeks. But for the most part, with endometriosis, it can come back. It can come back with a vengeance. And in some people, it can come back really fast. So I don't like to wait months and months and months to get to a transfer. But at the same time, I don't feel like you have to go right into a transfer either. And then the other thing is, ask your doctor if there was any adenomyosis that they saw in the uterus, and see if maybe you'd be a candidate for, let's say, 1 month of Depo-Lupron before you started your frozen embryo transfer meds. And really, I make those decisions based on how many embryos I have. So if I only have like 1 embryo and I work so hard to get it, maybe several cycles for a patient with endometriosis, I would say, I'm sorry, but I want to be super aggressive and talk about everything. Remember the one question we always ask? We always ask, before we do a transfer, what would we do if this transfer didn't work? And the reason why we ask that is sometimes that makes us brainstorm about things that we would do even before we do the transfer. So for example, if this transfer didn't work and you only had 1 embryo, you might say, oh, next time we're going to do a month of Depo-Lupron first. Well, this is the thing. You only have that 1 embryo. So why not consider doing that now? Okay. So this question's from Brittany. ERA receptive on Monday, ran out of progesterone the AM of the biopsy and had to borrow some. I gave 0.4 ml right at the right time, and another 0.6 ml about 1.5 hours later. Will my results be off? And no, Brittany, they won't. So if you were my patient and we had the biopsy today, I would say last progesterone yesterday, no big deal at all. So someone's asking how much ubiquinol, and I would say around 300 milligrams, 150 to 300, depends on the maker, but typically that much is what I recommend. 2 questions. Is there a chance that taking biotin can impact your AMH level? You know, CoQ10, any particular brand? And the answer is yes. Biotin can affect all of our levels. I've seen, what I would say is you can always stop it and then repeat it and then see if that makes a difference. As far as CoQ10, the brand that I recommend, Theralogics, THERALOGIX.com. You can use code TUSHY, all caps, for the PRC price that you see. It's NeoQ10, 1 to 2 capsules per day is what I recommend for my patients. Talk to your doctors and see what they recommend for you. So this is a great question from somebody, Shumaya Bang. Doctor, what are your thoughts on Clomid? You guys all know my thoughts on Clomid. I call Clomid Clomonster, and I say if you want Clomid, you can go find it at another clinic. I'm just kidding, but kind of not. I find Clomid to be one of the cruelest drugs to give someone who might be depressed, stressed out, and have anxiety. Because guess what? It causes depression, anxiety, and it makes you more stressed out because you feel like you want to kill somebody. That's why we call it Clomonster. You turn into a monster. Certainly not everybody feels that way, but a lot of people do. So much so that I tell patients to find the local Catholic church, call the priest, because you might need an exorcism when you're done with it. It can also make your vagina really, really dry. It can thin out your lining and be an anti-fertility drug. And it has been shown in very old studies that, prolonged use could increase your risk of cancer. We don't like cancer. We don't want cancer. We don't want to do anything to cause cancer in our patients. So I do not use Clomid. I like Femara, also known as letrozole. Saying Femara and letrozole is like saying Tylenol and acetaminophen. They're the exact same thing. So I prefer Femara for my patients. We use it off-label in fertility patients. You take it the same way, basically 5 nights. And there are other ways of doing it, 7 nights, 10 nights. And typically you start by cycle day 3, but you can even start day 2 or even as late as day 5 or 7, depending on your situation. But for the most part, it's very well tolerated. Very rarely patients have hot flashes or feel like they're losing their mind. The most common side effect is lower leg cramps, slight headaches, and I would say maybe like 1 in 40 will still get the hot flashes, but nothing near Clomid. You will not need an exorcism on the Femara, I promise you. This question is from Scorpna. Does FSH8 and progesterone 0.411? Okay, I'm 38 years old. So Scorpna, that's a great question. So progesterone doesn't tell us anything about your egg quality. AMH is a test we want to do. FSH and estradiol on cycle day number 3, 2. That rhymes. Okay, Joyce Moon is saying, do you think estradiol level of 3,800 right before egg retrieval is too high? Will it affect egg quality? So Joyce, 3,400 or 3,800 is super. So you guys know what to ask. Ask your doctor. What emergency numbers do you have for me in case I'm feeling kind of crummy and I need some help and assistance? What are you going to do to prevent me from having severe ovarian hyperstimulation syndrome? So let me just kind of give you my tips. Salty water. And salty water for me are electrolyte-rich drinks like Gatorade, G2, Propel, Powerade. That's what I mean. Protein drinks. Whey protein, WHEY. I tell my patients 3 scoops, scoop, 3 to 4 times a day after the trigger shot. Keeps OHSS away. There's a beautiful study published in Fertility and Sterility. It was an abstract, and I've been using it since I read it, and actually someone told me about it before I even read it, and then I read it, and I was like, I need to tell everybody about this. Bromocriptine, Femara, Ganirelix, these are all my little tips and tricks to keep patients safe and keep them out of the hospital and comfortable at home dealing with their swollen ovaries after they've gone through their egg retrieval. So my point is this, your 3,800 estradiol doesn't worry me at all, but just ask your doctor, what are my risks of having moderate to severe OHSS and what can I do to not have that? And part of it is just using the right dose of a trigger shot. A lot of times we like to use Lupron instead of HCG or use just a whiff of HCG hormone. And some doctors use an IV hydration system called Hespan to help with prevention of OHSS. Okay. Let's see here. Kate is saying, I'm 34 with unexplained infertility, had all the testing, 3 failed IUIs. Doctor wants to do a 4th with a higher dose of letrozole. Will this make any difference? Should I move on to IVF? Okay, so this is the thing, Kate. You want to ask, why are my IUIs not working? So if an IUI not working, it's either egg, sperm, uterus. Okay, let's talk about this. So the egg could be an egg quality issue, and you don't really know that until you do IVF. Sperm could be an egg fertilization issue, meaning the sperm can't fertilize the egg. And when I talk about uterus and tube, there could be an implantation issue, meaning there could be something wrong with the tube, not allowing the eggs to get picked up by the tube and not allowing embryos to just go down the, see what I mean? This is the embryo. Embryo traveling down. I am the uterus, if you didn't notice. That's what I was trying to show you. embryo landing into the uterus and sticking and growing. So that's the beauty of IVF with embryo creation. You bypass that egg issue of not making it into the tube. You bypass that fertilization issue, so you get the egg and sperm together inside a petri dish, and you bypass that embryo traveling down the embryo transport system, which is the freeway for the embryo, and you just put it inside the uterus. So that's why pregnancy rates with IVF are so much higher than natural conception. But this is the thing, before you even get to that, do dig deep and talk about what are my possible explanations for why I haven't been pregnant before you move forward, so that you feel like you have all the information you need. And you guys, go to What is IVF? It's in my draimee.org, draimee.org blog, and there's a beautiful pyramid. It's called the IVF Attrition Pyramid. And for anyone who's watching this who hasn't seen that pyramid, I recommend you print that pyramid out and bring it to your doctor before your IVF cycle and say, can you tell me what my pyramid will look like? It's really important to have hope, have only pragmatic and positive expectations. And so going into an IVF cycle with inaccurate or incorrect expectations of what the treatment should bring to you is really frustrating to find out later that there's all this stuff that you could have known first. So super important for me to educate you on that. Super important for me to talk to my patients about that. And I hope that helps you. So my thing is at 34 years old, I would say if you want 2 kids, if you are my patient, I would strongly recommend considering IVF. It doesn't mean you have to use the embryos right now. You can still try naturally, still try IUI, and save those embryos for later if you wanted to. This question is, I had a laparoscopic surgery early this year for a large endometrioma and another cyst showed up 4 months later. What do I do? Really wanted to start IVF. So I would still consider starting IVF. So IVF can be done in 4 steps. Step 1, diagnosis. Step 2, IVF is the embryo creation. Step 3, embryo transfer preparation. Step 4 is the transfer. The reason why I'm showing you those steps is because you don't have to worry about removing the cyst right now if your doctor doesn't think you need to. You can do the embryo creation first, and it sounds like your diagnosis is endometriosis, and it sounds like that could potentially be also affecting your fallopian tube. So make sure before you even transfer, ask your doctor, have you addressed my anatomy? Have you addressed the endometriosis before I transfer? Because we all know, every fertility doctor knows, that endometriosis reduces the implantation rate as well. So you want to treat it first as much as you can. So if your doctor thinks that it needs to be treated before an embryo goes in, I would say do so. Someone is dying laughing. I'm so glad. Okay. Thoughts on lipid infusion for a frozen embryo transfer. What is your experience with day 7 embryos? My only 2 are both day 7, chromosomally normal. Just wondering what our chances are. My clinic does not have any data. Okay, Jessica. So my thoughts on intralipid infusions for a frozen embryo transfer are this. If you feel like you need it, go do it. It's not a big deal. It's like going to Jamba Juice. Instead of drinking a smoothie, you're putting it through your IV. Is it a little more annoying? Yeah, it is, because you got to sit there with an IV in your arm for 2 hours. Do I offer these to my patients? Sure. If you come to me and say you want it, I'll be like, fine. At the end of the day, do I think it really helps? I don't know. Probably not, but I think in some cases, well, in most cases it doesn't hurt. But in some cases, was it that something that I did differently that made it so that a transfer worked? Still probably not. But at the end of the day, if someone really believes that they need that for what's going on with them, I'm happy to do it. So those are my thoughts. I usually order it on the day of the lining check, and then every 4 weeks until you're about 20 weeks pregnant. And a lot of times we just stop at the heartbeat ultrasound. So as far as your question about day 7 embryos, my thing is this. Day 7 embryo pregnancy rates are a little bit lower, but also depends on what was going on that embryo day 5, 6, and up to day 7. Because sometimes you can have a day 6 embryo that looks like it's almost ready to biopsy. It's really pretty, but not quite yet. And so from a safety standpoint, you want to move it to day 7. But if it's a really poor quality day 7 blastocyst, that's a different story. We're talking about a very low chance of pregnancy. So ask your doctor, what is my chance of pregnancy if this embryo was a day 6 embryo? I think that question is actually probably the best one to ask if your clinic can't give you any data on day 7. And then I would just take 10% off. That's kind of what I would think if it were me. So Jessica is asking if 6BB is what they are both graded. Oh, okay. Only 1 retrieval, and this is our first transfer. Thank you, Jessica, for that additional information. So a 6BB, that's pretty great. A 6BB day 5, I would say probably if it's genetically normal in your lab, I bet they would tell you at least 65% live birth rate. But talk to them and then just reduce it by 10, and I bet it would be closer to 55. So definitely a chance. Brittany is saying, IVF is in my future. I had a consult about 2 years ago. We should have the money saved in 6 to 9 months. When would you recommend reaching out to the clinic? I'm 30 years old. Brittany, I would reach out now. There's no reason to wait. Do all the tests that I kind of talked to you about, the Tushy method, the balls method. look at your tushy, look at the balls, and really there is a website, ballsmethod.com. You can go there. Believe me, it exists. And make sure you've done all the tests and ask your doctor, what can I do that's in my control to give myself the best chance of pregnancy? And then you have so much time to ask and be like, what medications are you giving me and why? Why is this the protocol that you have chosen for me? Print out that IVF pyramid that I talked to you about, bring it in and ask them to kind of share that with you and ask them how many IVF cycles will I need for the family size that I want and what are your expectations for treatment outcomes for me? Easy, right? Not so fast. It's really hard. I'm just going to take a drink of my coffee here. And if you didn't notice, that is me. That's how I look when I'm at work. Okay, so this is Night Nurse. I'm 42 and I'm doing IVF for the third time, only taking CoQ10, starting your suggested supplements. Will it help my husband and I retrieval around November 7th? Yes, I would say at 42, I have definitely seen improvements in egg quality. I know. People are rolling their eyes out there and they're like, how can you improve egg quality? And my thing is like, in some people, I think you can. You can't do it for everybody. And I don't know why. Some people respond better to these egg quality supplements than others. For some people, I don't see any difference at all, but in other people, I do. And so I feel like if it were up to me, I would want you to take them and see what happens because I don't see any harm in taking them. They can't hurt at all. So good luck on November 7th. So Jen Bessick is saying semen analysis shows morphology of 1%. Is IVF the way to go? So Jen, it just really depends on, have you done other treatments? You could potentially still get pregnant naturally or with IUI with a 1% or more for morphology, but let's, take a step back. Let's figure out, why is the sperm that way? What is causing it? Is it genetic? Is it anatomic? Is it lifestyle? Is it hormonal? See, I'm going through the balls method, you guys. So make sure there's no varicocele. Do a DNA fragmentation test. Look at his lifestyle. Don't cook your balls. I walk around with a t-shirt when I'm not here that says, don't cook your balls, but I feel like it should say something else like, don't heat up your sperm or else they will not be as good. But nowadays, everyone is smoking weed, like everybody. I feel like it's in the water or it's in the air. And so weed is bad, and that can cause low morphology. So don't smoke weed. PSA for today. Okay, let's say, oh my God, someone has the name semen analysis right now as I'm going through these questions. So Weddy is saying, you're so amazing. Your knowledge is incredible. I love listening to you. Thank you. I did not pay you for that. Which way for OHSS? Ladybugs, I don't really know which way. I just tell people Google whey protein. No, I'm just kidding. I know there are a lot of plant-based brands. There's one brand. I can't remember the brand, but someone told me about it and they said it was so good and natural and I can't remember it right now. But for example, Muscle Milk makes a brand of whey protein. You can even get it from Jamba Juice, but there are a lot of different resources online for that. So someone is saying, do IVF medications make endometriomas worse? After 2 retrievals, I started feeling pain on my right side. Is there a chance my endometriomas got bigger? Absolutely. Yes. I always tell patients all the time, these medications could most likely make your endometrioma worse. And if you've had, let's say, a laparoscopy, they can cause the endometriosis to come back again and be worse. So absolutely. So my happy place is asking, hi, Dr. Aimee, is there anything I can do to have more follicles in my ovaries before my egg retrieval? I wish there was something we can do to grow more eggs. We can't. There's cycle to cycle variability. Some cycles would be better than others. Believe it or not, like I've had some patients, they come in one cycle, there's like 3 to 4 follicles. Then the next cycle, there's like 8 to 9. You're like, oh my God, I'm glad we waited. So that's why I like to look at the whole picture. Look at your AMH, your FSH, your age, and look at the history. Look at what your follicles have been looking like over time, and then make sure that cycle you're going in for and getting all those eggs is the right cycle for you. Start your meds and don't feel any pressure to complete the cycle. I don't think of things as canceling. Like I did an IVF cycle and was canceled. I think of things, I did an IVF cycle and we decided that this wasn't the best one for us. It's as simple as that. It just didn't work out this month. And we're just tracking and trending things and make sure that we're doing everything right so that when we actually do the cycle, it works, and hopefully the first time, but I know it doesn't always do that. Okay. Salute Amor. I love that name. Dr. Aimee is language genius, explaining what matters in IUI so well. Thank you very much. So Joyce Moon is saying, Dr. Aimee, after an IVF egg retrieval, is it normal to have the period blood color more bright red? Yes. So listen, I used to tell people that the period after your egg retrieval was like a murder scene. And I realized that's really horrible to say, that I shouldn't say that. So then I changed it. And I said, it's like a waterfall. A waterfall sounds a lot better than what I just said. But the reality is that it can be like a really, 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 really loud waterfall. And I've had patients call me, they're like, oh my God, what happened? I'm bleeding. It's like leaking down my leg. And that's what I mean by what I just said. And that's why I always prepare patients. I'm always like, this period is going to be the period of all periods. And your mood changes are going to be like the worst PMS of your life. And then believe it or not, I have patients that are like, this period was so easy. What's wrong? And I'm like, you're just lucky. I just prepared you for something that could have been horrible, but it wasn't. So I'm really happy. So this person is asking, do you have a lot of success stories with couples dealing with severe male factor infertility? Our doctor is talking to us about adoption. We just don't want to give up just yet. I would say it just really depends on, the sperm quality, fertilization rate, embryo progression, and what your doctor thinks. And I would say get another opinion before you start worrying that this isn't doable for you, and see what other doctors have to say. But also meet with the best of the best male fertility specialists, urologists that can really guide you as well with their experience in cases like yours. Maria is saying, should healthy 35 to 37-year-old normal to high, let's see here. I don't understand that question, but I think the list of supplements that you're giving me, CoQ10, DHA, prenatal, D3, folate, all sound great. I would say if your FSH level's high, your AMH is slightly low, certainly do consider taking the supplements that I recommend on this show, like NAD and pterostilbene. This is a question about a fertility clinic offering Golden Egg IV. It's basically some vitamins they give you with IV. Do you recommend that? I would say if you want it, take it. See what experiences they have with it. I'm not sure what's in Golden Egg IV, but that sounds pretty snazzy to me. But only do it if you feel like it's going to be a good use of your time and you have the time to do that. So Jessica is saying, do you use Depo-Lupron often in patients that have endometriosis? And the answer is I do. I use it a lot, but I always tell patients this: get your survivor kit ready. I tell them to Google Depo-Lupron and read about all the crappy stuff people say about it online, because if it happened to you and you didn't know it could happen to you, then you're going to feel horrible that someone didn't say it could happen to you. So it can be pretty horrible to go through it if you realize that you hate it and then it's in your system for 1 month. I typically recommend the 30-day dosing of it. I don't want patients to be on it for 3 months. There are some situations where I do have patients on the 3-month version, but for the most part, I do 1 month at a time. And I tell patients, look, if you're done after 1 month, we don't have to go to 2 or 3. Some cases I just tell patients to do 1 month, and some patients I do ask them to do 2 or 3 depending on their situation. This next question is this: after 3 rounds of letrozole and 2 rounds of Clomid not working, is it time to go to IVF? I'm 29. So it just depends on why they're not working. Is it that you didn't respond well? Is it that you ovulated? Was it the sperm quality that wasn't good? What is your diagnosis? Go to tushimethod.com. Do the 5 tests that I talk about that are part of fertility screening made easy. Get your tube test done, look at your uterus, look at sperm, do all your hormone and preconception labs, and look at your genetics, and make sure you haven't missed anything before you move on to IVF. But yeah, if you're feeling like enough's enough and you just want to move on and do IVF, do it. We talk to young people all the time about freezing their eggs. It sounds like you want a family now. Don't just freeze eggs. Do the F part of the IV part and freeze embryos. So Elizabeth is asking, how long should you take CoQ10 before egg retrieval? Mid-treatment right now, is it worth starting, or is it too late to make a difference? Just start it now. I want all young, like anyone, and 38 years old is young. I want everyone to take CoQ10 until they're done with their kids. It's as simple as that. I think what we're going to find, my hypothesis only, but based on animal studies, what I hypothesize is that young women who took CoQ10 in their 20s will potentially be more fertile in their late 30s and early 40s than women who didn't start taking it in their 20s. Is it something that if you started today, it can help quality next month? I actually do think so, and I've seen that. I've actually had patients no CoQ10 do a cycle, then 1 month of CoQ10 and cycle, and the outcome is different. And I don't think that I have something so wonderful here that all of a sudden it was just me that made the difference. I do think that CoQ10 can make a difference like that. Okay, let's see here. Great questions. This is, what are the biggest red flags when assessing lab and lab quality? Like oxygen levels in incubators, biopsy survival rate. So I would just ask, how long have your embryologists been working there? How many PhDs do you have? How many cycles do you do a year? Who does your blast biopsies? Do you guys have any people that come in on a rotating basis, like travelers? I think those are the questions that I would ask if it were me. And it's hard to, and I've actually done a show on these very things with Dr. Carol Kershaw, Curchoe. So go to my YouTube channel, Egg Whisperers Show on YouTube, and I would find some of the shows that I've done with Dr. Carol, and we talk exactly about this. We talk about like a guide as far as like what to do or how to find the best IVF lab in your area. So this is a question from The Making of Baby D. What do you do to improve a thin endometrial lining before a frozen embryo transfer? So there are lots of things you can do. You can do vitamins like L-arginine and vitamin E. Take baby aspirin. You can change up the protocol, like take an estrogen shot, maybe add a patch to your estrogen pills, increase your pill dosage, take it in different ways, like vaginally, orally. You can't snort your estrogen, you just put it in your rectum. I promise you it's been tried. I'm just kidding. If it has been, I don't want to know. And then there are all sorts of other more creative things that you can do. For example, PRP infusion inside the uterus. I have seen a benefit to HBOT, which is hyperbaric oxygen therapy. Other like outside of the box things that you can consider doing for a thin lining would be more like a natural cycle transfer, not so much outside the box, but also stimulate your ovaries as if you were to do, let's say, an IVF cycle. And then with that, then you can put an embryo in. So ask your doctor, what was my lining like during the IVF cycle? And if the lining was good, then perhaps consider ovarian hyperstimulation to get your ovaries making all that estrogen to get your lining thick. And last but not least, rule out Asherman syndrome with a saline sonogram, hysteroscopy, or both. Okay, so someone's saying, I read that supplements will only help if taken 3 months prior. I don't believe in that. I do think that it can help eggs now. Moneybees is saying it took us 15 months to get pregnant with the boy-girl twins, made it to 7 weeks, and the cervix gave and the water broke. I'm sorry, I had to have a DNC. I'm trying again for the past 5 months and not pregnant yet. I'm 38. Is IVF the way to go? Yes, Moni, I'm sorry about what happened to you. I mean, deeply sorry that you had that experience, and it's devastating. I mean, those are the experience that loss is something that we will, those babies will cherish for the rest of our lives. And I'm sorry you had that happen to you. But yeah, I would say check your AMH level, do your day 3 FSH and see what's going on. And I would say if you're not pregnant in the next month or two, I would definitely start preparing for IVF and talk to your doctor about how to best prepare. And remember that IVF pyramid that we talked about that you can find on my website. So someone just suggested organic whey protein from Garden of Life. Excellent. Thank you for that suggestion. How do you decide for patients how much Coke you tend to take when, say, 1 to 2 capsules? Well, that's a great question, Ren. It just depends on how you tolerate these vitamins. Some people get an upset stomach. Some people get reflux. Some people get nauseous. And I don't want to torture people. There's no need to tough it out. I want you to enjoy life and have fun as you're going through this process. I think of IVF as is very fun, and someone put I'm used to snarky comments, and someone put a snarky comment somewhere on social media that says, oh, you have no idea what you're talking about. There's nothing fun about it. And of course it's not fun. Of course it isn't. But taking a whole bunch of supplements is not supposed to be fun. But I want us to find the joy and find the fun in everything that we do every day, no matter how tough it is. And IVF is certainly very tough. But for patients who are taking supplements, I don't want them to take thousands of supplements a day. So I would say start with 1, see how you feel. If you're feeling good, then go up to 2. But I would say I don't necessarily know that 1 or 2 makes a big difference, but sometimes I do suggest 2. Sometimes I even go higher. Someone's saying, Vienna, would you please have an Amazon list of vitamins? I should. I'm 38 years old, just had a full workup, progesterone 0.4, estradiol 65, FSH is 8, LH is 4. What are your thoughts? So what I would say is get your AMH level checked. Okay, so someone's saying, tell me where I can get those cool ultrasound pants. Yes, get them from eggwhisperpants.com. And thank you, infertile scientists, for asking that question, eggwhisperpants.com. Another question is, should we take the supplements every day at the same time? Can we take them together? I would just go ahead and split them up during the day rather than taking it all together. There's so many creative ways of splitting up your supplements with a pill box. Someone is asking, have I heard of IMC? And the answer is, I have. Not every clinic does it. A lot of clinics outside the country do it, but not so much in the Bay Area. What IVF protocol do you recommend for super low AMH patients? I was on 300 units. Going all 75 of Menopur and started Cetrotide on stim day 6. So waiting for our miracle with super low AMH, I would say consider a hybrid protocol or a mini IVF type protocol. Starting with letrozole, coming in, seeing how your ovaries look, then adding the injections from there. If you only have a follicle count of 1 to 2, I don't see the point or purpose of, taking such a high dose of medications. That's from my perspective. So So someone's saying, Maria, would you ever do an ERA biopsy on a first timer in her mid-30s with normal ovarian reserve? And the answer is, Maria, I would, depending on how many embryos you have, depending on the quality. And then we would talk about, do we need to do an ERA based on your family size goals with the embryos that we have? And so typically that's a conversation I have with each patient. It isn't a one-size-fits-all decision to do the ERA test. Vienna is saying, what do you think about intracytoplasmic morphologically selected sperm injection? I had a failed cycle due to male factor. Thank you. So here I do more pixie. So you pick a pixie dish and put the sperm on top. And there are other ways of picking the sperm out in a more stringent way, like, for example, Zymot, Z-Y-M-O-T. So Marion's saying, I had a hysteroscopy 4 months postpartum for a tame placenta. The biopsy report showed an endometrial polyp in a small area of hyalinized material with calcifications. Is this concerning? No, I would say thank goodness they removed it. It's not concerning at all, but my concern is that can cause scarring for future babies. So I would say make sure you've talked to your doctor about doing a saline sonogram before you're ready to get pregnant again to make sure there's no scarring and everything was safely removed. So this is from Libby. What protocol do you typically recommend for patients with DOR and endo? So I would recommend a protocol to maximize our chances to get as many eggs as we possibly can. I would also consider embryo banking to make sure we had enough embryos for the family size that you want before we actually transfer. And last but not least, talk to your doctor about treating the endo before doing an embryo transfer and looking at your fallopian tubes, because we know that fallopian tubes can be affected by endo, and sometimes patients are at high risk of having a hydrosalpinx. And last but not least, talk to your doctor about the egg whisperer diet. So we know your diet, the D is diagnosis, which is endometriosis in your case, and it sounds like DOR. The I is creating an IVF cycle to support those and give us whatever chance, the best that we can to have success. The E is endometrial testing. So looking at the lining of the uterus or embryo transfer preparation, and those are all the things that I talked about. And doing a test, for example, like the Receptiva test to look at endometriosis in the uterus to see if you would be a candidate for maybe a laparoscopy or Depo-Lupron, for example. And there are a number of medical ways of dealing with endometriosis now, like Orlissa and Femera, so that you don't have to feel like you have to take a Depo-Lupron shot before your transfer. Someone is saying, I will call your office for a consult. I have way too many questions. I can stay here all day, let me tell you. This is from Amb52. I was supposed to start IVF this month and asked if I had to stop breastfeeding when I start birth control. They said now I have to wait 2 months. I only fed once a day and not every day. Is this 2 month standard? I don't make patients stop breastfeeding. I don't think there's a need to. These injections are not something you can swallow. So if I took a Gonal-F shot and put it in my mouth and swallowed it, I can tell you that there's not going to be any ovarian stimulation. And that's why these medications have to be injected. So imagine a little baby and you're breastfeeding that baby and you've done a shot in your tummy. That medication is not going to be orally digested by your baby, and those ovaries or the penis, whatever it is, the organ that they're worried about, is not going to be affected. However, breastfeeding can affect the hormones can affect your breast milk. So with that in mind, I would say if you're ready to just stop completely, that could happen just naturally. You can naturally be weaning your baby at the time of IVF. The other thing I tell people is, look, like as your estrogen levels get super high and you're under anesthesia and have those medications in your system, if you think about it, when you're pregnant and you're delivering a baby, your hormone levels are super high and you go under anesthesia, like have an epidural or have a C-section and you have those same anesthesia medications. How is it so different? I don't really know. I don't think it is. So I don't get too paranoid about that. I want patients to move forward on their own timelines. And I do have patients that breastfeed even in the first trimester of pregnancy. So every doctor's style is different. The way we talk to patients, our outlook and our approach. And I know there are other doctors just like me, but sometimes I suggest pumping and dumping for that week or so in between, right before the egg retrieval until a little bit after the transfer. So talk to your doctor. One of the tests I always do is a prolactin level, just to make sure the prolactin is nice and low before we start. But most patients who are breastfeeding as they're getting ready for their next transfer aren't breastfeeding so much that the baby is using that breast milk for nutritional purposes, is more for soothing purposes. And so right now we want to soothe our babies as much as possible because of COVID. So this question is from Libby. Sorry, last add-on question to my last. I had the Receptiva test and my level was 4. So high. Should I do laparoscopy or consider Lupron with such a high score? So it really depends. So if you have signs of endometriosis anatomically, meaning you have large endometriomas or you have what might look like adenomyosis with that, it might not be a bad idea to maybe even consider doing both. So when they go in, they can also look at your fallopian tubes and make sure there isn't a hydrosalpinx. So if you were a patient of mine, I would look at how many embryos you have first. I would make sure I had enough embryos before I started doing all of that, because the Depo-Lupron and the surgery could really affect your ovarian reserve. So like I said, that's what I would consider doing, but see what's right for you and talk to your doctor about doing that. So Marianne is asking, have you heard of fertility? That sounds like a cool thing. I haven't. It sounds like I have not heard of that. So Maria is saying, what pretreatment would you use for antagonist protocol for someone who's 37, AFC 16, AMH4, birth control pills, estrogen priming? Nothing. What indicators would you look at to determine this? So I would say if your follicle count was over 16 and your AMH was 4, I would say I might want to consider birth control pills to prevent severe ovarian hyperstimulation, especially if you were on the thinner side. However, in general, if I felt like you weren't at risk for a severe ovarian hyperstimulation syndrome, I would probably just do a natural cycle start, meaning period starts, cycle starts, and you start hormones cycle day 2. This is a question from Flan. Daughter has stage 3 endometriosis and 1 blocked fallopian tube. Doc wants to do a robotic surgery. Is this something you recommend? Her backside of the uterus is covered with endo as well as bowel. So yeah, I mean, what I would say is, would the surgery affect her ovarian reserve? If they'll be removing big cysts of endometriosis, I would say there might be a benefit to doing that before an IVF cycle, but I would talk to a fertility doctor first to see if she should do IVF for embryo creation purposes first, and then do the surgery second, and then go right into the transfer. The reason why I don't recommend doing surgery first in a lot of cases is that we know that IVF stimulation can stimulate endometriosis, and that just seems silly. You're going to remove the endometriosis, then you're going to stimulate endometriosis, and then you might need to do surgery again because you've stimulated endometriosis. You get what I'm saying? So I would just make sure you're talking through all the different options and scenarios first, so you're not feeling like, why didn't I know this? And make sure you've had your AMH checked. So let's see here. Someone is saying that there's a shortage of brand name estrogen. Is it okay to use generic estradiol? And the answer is yes. We all use generic around here. My wife used progesterone suppositories last successful transfer. I do like those vaginal suppositories. They don't hurt as much as the shots. So Pav is saying, do you recommend birth control after laparoscopic surgery for stage 4 endo before starting IVF retrieval? And so I would say it depends on the AMH level. I'm concerned about over-suppressing of the ovaries and waiting too long to start an IVF cycle. So it just kind of depends on what happened at the time of laparoscopy, what the AMH level is. Would I risk too much suppression if I started birth control pills and then decide from there? Philip says, my wife used progesterone suppositories last successful transfer with a live birth, but I hear so many REIs only use oil suppositories. So Philip, this is the thing. I think suppositories can be as good as the progesterone shots, but if you skip one, all your efforts are done. And to forget is like being human. So I have patients that are like, I forgot my suppository this morning. And I'm like, you're done. I'm sorry. You get the shot. Like, no more suppositories for you. No more for you. So I tell my patients 8, 2, and 8. If you're late, I will be irate. Literally. And so I tell patients, like, this whole sleeping in thing, like when you're supposed to do your suppository at 8 a.m., that's not happening anymore. You're waking your butt up, setting an alarm and waking up at 8. And like waking up at like 11, be like, oh, I forgot my 8 o'clock suppository. Like, your pregnancy will not get any progesterone. So if you feel like you're going to sleep in the next morning, set an alarm or do one really late at night so that I don't like more than 12 hours to pass from the last suppository of the night to the first one of the morning. So those are my tips for those of you guys who are doing this. Night nurse is saying, I work night shifts. Do you think I should be taking time off when I start my injections for IVF? Do I need to be resting or is it okay to work? What do you recommend? Yes, night nurse, if you're a patient of mine, no work at night during your IVF. And then honestly, pregnancy and life is so short, but your pregnancy is so important. I want you to do anything and everything to, support your pregnancy, and sleeping and having a normal circadian rhythm is part of that. So if you were a patient of mine, I would talk to you about the possibility of not working nights and working a day shift instead of doing night nursing. So Vividi has a great question. If you estrogen prime too early after ovulation, can that cause progesterone levels not to rise and therefore prevent your period from coming? Yes. So, if you start estrogen too soon and you haven't ovulated, it could potentially prevent ovulation. If you start it too soon, I don't see, if it's way after ovulation, how it could inhibit your period from starting, unless it's a really high dose of estrogen. Then it might inhibit your period from starting. Someone's asking, what's the success rate for IUI? And success rate for IUI is anywhere from 5 to sometimes 20%. It just depends on how many eggs you're ovulating, your age, and your total diagnosis. That's something that I tell my patients when they're doing IUI. So let's see here. Someone's asking if I have a specific brand of acai berry that I recommend. I say no, I don't really have a specific brand. When do you recommend Omnitrope or HGH? So I recommend it in someone who has had a previous IVF cycle without success. I recommend it in anyone with an elevated FSH or anyone in general who has a diagnosis of DOR. I recommend it for everyone over the age of 40, no matter your diagnosis, whether it's a first or second IVF cycle that you've done. And I think I covered it all. So Pretty Petaway says, friend wants to do IVF at 44 with an AFC of 4. Should she go for it? And the answer is yes. I don't see any reason not to. What I tell my patients, if I could get at least 3 mature eggs, it's worth it, in my opinion, to go for it. Understanding that you have to have hope, have only pragmatic and practical expectations about what the treatment outcome will be. Go into it expecting it's not going to work. But at 44, you're a young woman. You have the rest of your life to live. I don't want you to look back and be like, why didn't I try when I still had 4 eggs? Because 100% of us, 100, no one can get away from infertility. It is inevitable. Every single woman has infertility at some point in her life. Everyone runs out of healthy eggs. But the thing is this, just because we run out of healthy eggs does not mean we run out of the desire to have a healthy pregnancy and be a mom. I mean, look at Sia. Did you guys see the headlines? Sia just adopted 2 boys. They're 18. And she's like, being a mother is the best thing I've ever done in my life. I'm like, you adopted 18-year-old boys. I mean, I would call them men, not necessarily boys. But that just shows that she's over 50 and being a mother is the most important thing to her now. And that's like pretty incredible. So that just shows that just because you've run out of eggs doesn't mean you run out of the desire to be a mom. And at 44, you're pretty darn close to running out of eggs because that's just normal stuff. Most women can't get pregnant over the age of even 40. And most of us can't get pregnant over the age of 42. And at 44, I don't want you to look back and have any regret. So go for it if you want to. Okay. So Marianne is saying, there have been so many celebrity pregnancy announcements during COVID times. Their announcements can be so insensitive. I agree. They're so insensitive, and a lot of them are annoying, and I couldn't agree more. Okay, you guys, I love you all. There's one last question, and then I'm going to close out tonight's Ask the Egg Whisperer. I don't want you guys to get sick of me and not want to come back and listen to me, because I just would cry, because it's too much fun to be here. So Night Nurse is saying, regarding the night shift, do I stop working while I do the injections till egg retrieval? Day shift is not possible, so is that not enough time to take off? Okay. So yes, do whatever you can to work days up until the egg retrieval. Absolutely, and don't worry about it. Do whatever you can. I know you have to make a living. That's just kind of important to be able to afford to, support your baby and your future baby and future family. But at the same time, there's no one more important than you and this IVF cycle right now. So I want you to put yourself first and do whatever you can to do that. And it sounds like you definitely are. So I'm glad you're asking. Okay, guys. I love you guys. I hope you guys have a wonderful night. I'll be back here tomorrow, and I'll be back here next week and the following week and the week after that. And keep sparkling and keep doing what you're doing to find joy in each and every day and each and every moment of every day. And remember, when someone asks you, how are you doing? Remember, it's so easy to say, I'm just barely hanging on. But remember, how are you doing? I'm feeling strong and resilient. And keep doing what you're doing, you guys. Keep chasing your dreams because it truly is so worth it. Okay? I love you guys, and I'll see you guys next time. Bye, guys.